Um, Jamie, why don't you go first? I'll let you introduce yourself.
You bet. My name's Jamie Nordhagen. I'm the Director of Patient Flow and Capacity Management at the University of Colorado Hospital of UC Health.
Excellent. Thank you, Jamie. So my name is Pallavi Sanyal Day, and I'm the Director of Client Services for our inpatient beds product called IQ for Inpatient Beds. Outside of that, I've been an SHM member for years. I helped start up our SF Bay Area chapter. I'm part of the Practice Management Committee and have always really enjoyed attending the conference. This is our first year doing this whole virtual thing, so it's new space. But I'm so excited to be a part of this. And Jamie, I'm so excited that you were able to make this. And we're excited to talk about capacity as it stands. And as we know, it's at the top of our topics as we've dealt with the pandemic and all the things that have happened over the past year. I wanted to tell you a little bit also about, since we are going to be sharing technology that my company has used and is partnered with the University of Colorado to help further develop. So Leantas is the name of our company, and we believe in lean principles, and it's operating off of a SaaS platform. We are based out of San Francisco, Silicon Valley. We also have offices in Charlotte. We have a good amount of investing that really has gotten into predictive analytics itself. I won't repeat all these numbers. You can see them right up here. We have many, many partners across the nation. And in particular, I did want to highlight, we have three specific areas in which our products lie. One is for infusions, so chemo infusion centers, things like that. The other product is for operating rooms, how to optimize the usage of operating rooms. We will specifically be focusing on inpatient beds currently. The other thing I did want to highlight also is that our founders of Leantas have really delved into clinical operations research and honestly just really how to marry the use of machine learning and AI and use math, and how can we use math and technology to improve clinical operations. So they wrote a book called Better Healthcare Through Math. And if at the end of the session you are interested in finding out more or would like a copy, we'll give some information so you can obtain a copy of this, both electronic or an actual version. So that is us. This is actually focusing a little bit on the problems we wanted to really highlight as we tackled the inpatient capacity problem. Quickly, I will just say the following. One is lack of visibility. So visibility has been a key issue in capacity, but initially it was mostly, okay, just getting an idea of what your current real time looks like was challenging and continues to be challenging in many places. Now with kind of better versions of our EMR and better ways to kind of understand the data, people are getting a handle of current real-time data more and more, and they're being able to use it in their operations. What still remains missing, however, is the ability to look into your future. And so that is where IQ comes in, into really focusing on what are the next several hours going to look like for your hospital with regards to capacity. The other thing we focus on is decision making. So for all of us in the clinical world, we are very used to putting out fires, both clinically and operationally. One thing that is operationally hard to do is to proactively prep for potential things that will happen down the road, because there are so many things out of our control and hard to predict, or so one would think. However, based on the years of work that we have done with trying to figure out how can we accurately predict so that folks can actually proactively problem solve for things that will happen in the future, we have come upon models that work, and we've embedded that mathematical modeling and prescriptive kind of recommendations into the tool, such that you're no longer reacting, but you are in advance kind of prepping the team and making decisions so as to improve what's going to happen in the near future. The third thing, of course, which is always the truth when it comes to hospitals, is that it is always an unpredictable kind of inpatient flow when it comes to admissions and discharges. However, once a patient is admitted, there is a level of control one can have as to how that patient moves within the system once they are admitted. And we have delved into that arena by focusing on internal transfers in certain ways. And the last piece that I want to highlight is, of course, you cannot talk about patient flow without touching upon discharges. So part of our tool really focuses on that discharge flow, because as you all also checked off in that question, that is one of the number one things you all think about as an issue, because discharge delays can contribute hugely to the patient flow issue. Okay. Jamie, I'm going to hand it off to you here because we'd love to learn more about University of Colorado and the healthcare system.
All right, thank you. So a little bit about our system. We are a 12 hospital system with our flagship organization being the University of Colorado Hospital, located in Aurora, Colorado, right a suburb of Denver. We have at the University of Colorado Hospital actually, we're going to get to that slide next to explain more about UCH. You can see the metrics here, what our volume looks like across the entire system. Our system is community hospitals ranging in size from critical access to upwards of 500 beds. We are located all along the I-25 corridor of Colorado. Go ahead. Here are some interesting numbers about our system in terms of our patient population. So we cared for 691,000 Medicaid outpatient visits over the last fiscal year, with a 203% increase in Medicaid care since 2013. And Medicaid covers 25% of our total inpatients within our system. All right, here is a little bit about the University of Colorado Hospital. We are approaching 700 beds at UCH. We are actually currently building a third tower that will have us approaching 800 here in a couple of years. You can see our metrics here. Inpatient admissions, we typically sit around 5,000 with about 137,000 ED visits annually at the organization that I work at. Next slide. All right, this is a screenshot of what we used to distribute pretty globally across our organization. My house supervisors, hospital managers would collect this data throughout the day and email this out. The challenges with this is it was pretty workload intensive, and it was really just a snapshot in time. And so we had historically created a predictive model internally that was relatively clunky, that took a lot of copying and pasting and pulling reports from teletracking and Excel, and a fair amount of user, I wouldn't say errors, but intricacies. And even the timing of when this went out, with it being a snapshot in time, created challenges for us. So it was workload intensive, individualized, and not always very accurate, which ultimately resulted in a lot of chaos day to day for us in how we managed capacity and patient flow. Next slide.
Jamie, actually, one quick question. How long were you all using this format? Do you feel like it was a good couple of years?
Yeah, good question. So we used this format, I would say, for about 4 years. Different versions of it. We would modify it. We would update it. It took manual updating quarterly, where we would run our trends in terms of our admission volumes day to day, night shift, day shift, where they were coming from. And we would have to take those trends and update our predictive model through formulas and Excel spreadsheets. So a lot of work over many years. Yep.
Okay. Let's see. Okay. So at this point, we wanted to introduce the tool. that Jamie is now using, and we partnered with Jamie and her team also to help develop even further based on the needs that we discovered. What you will see here is just a summary of some of the pages that appear in our tool. Something called the house summary detail, which is kind of the 50,000 foot view, and it's our unit detail. There's a piece that focuses on admissions, and then there's a piece that really focuses on internal transfer movement. We're going to take a little bit of a deeper dive into each of these sections. And Jamie, I'll ask you to also relay to us how it's going, how you all are using it specifically. So first off, the house summary, as I mentioned, our big thing here was we wanted to be able to give that 50,000 foot view of what is your system going to look like over the next 24 plus hours. And so that was the intention of this page. And in order to give that quick understanding and grasp, we, of course, the highlight is around our models and what it is predicting will happen throughout the next several hours, but we had to also bring in key pieces of operational current utilization data that helped round out the picture as to what things might affect kind of an overall higher level understanding of what the situation is. Jamie, can you take us through a little bit about how you use the house summary page right now?
You bet. So the house summary is really our source of truth and what drives on our hardwiring of our patient flow, standard operating procedures, day over day. So this is what we pull up every morning at our bed meeting. And we review where we're sitting at as an organization in terms of utilization, our ED borders, how many ICU beds we have available, our COVID census, our predicted discharges, you can see at the top. It even drills down to how many discharge orders active we have right now, and then what our predicted input is. And so that allows us, with the predicted balance up in the right corner, to really proactively plan how we're going to work today so that we can stay out of trouble and prevent chaos the next day. If we are under beds in terms of minus, you can see the -4 there. That's going to drive us to open up more surge spaces. It's going to drive us to drill down into discharge delays. So it really drives our SOP every day in terms of patient flow and capacity.
Great, thank you, Jamie. I'm going to move on to the unit detail. And so this part of the tool focuses specifically on the units, of course, as said in the title. And it really highlights our models in particular. Now, what you are seeing here is probably going to look like a boring set of numbers and columns. What is going on here is actually quite intriguing and interesting, and it really reflects kind of the magic part of the tool. So I'm going to actually ask you to look at the predicted remaining piece of this page. And what we've done is we have spent a lot of time trying to figure out how can one best create a mathematical model that will accurately reflect what your bed balance will be like for hours from now. And how can we make sure that we're giving people the right prediction so that they can trust it and they can act off of it? And we were able to gather a whole host of variables, including variables that really capture the culture of that said unit. So that would include things like what kind of patient population is coming to that said unit, what level of care is being offered on that said unit, what is the staffing for that said unit, what time of day, what day of week is it. A handful of patient characteristics are also being pulled into the model, in addition to historical data several years back, and then of course the real-time data that is feeding in. And those models then are fed into this page and update on an hourly basis the predictions for every unit. So for example, Maine, let's do this one. Let's do Maine 10 Southwest. We'll have 24 different unique models that will be fed into this page and reflect throughout the day what the bed balance will be like as new patients come and go, and as our models run throughout the day based on what we have seen. Jamie, to provide kind of the real-time context, how is that useful to you? What are you doing at UC Health?
So we actually also pull this up at our daily bed meeting, and it allows us to look in the early morning there, 8 a.m., where our bottlenecks are going to be and where we are upside down in terms of demand and capacity. And so if we have a heavy OR day, one of our trends is either orthopedics or neurosurgery. And so on those heavy OR days, you can tell that we're upside down, and we need to see if there's off service on either of those units that we can potentially lateral to create space to accommodate the volume for that day. So we can very quickly look to the far right there in that column to see what that unit's bed balance is and where we can start to pull levers to try and get patients to the right unit the first time.
Wonderful. One thing we're not showing here is in the active tool, when you actually go to every single unit, it highlights that unit. And then if you go deeper within that unit, it pulls up, the hourly 2-hour chunks as to what the predictions are throughout the day for that said unit. And it will adjust in real time also with data coming in. And the other thing, Jamie, I was curious because before IQ, kind of what were you discussing in your bed meetings, and now how has it changed? Because it revolves with the tool.
So traditionally at our bed meeting, we would go unit by unit. We struggled to really have a source of truth that encompassed everything, doc line admissions, procedural admissions, direct admissions, transfers. And so this really is a one-stop shop. We used to have each unit report out what their demand was, what their discharges were. And that's what that unit thought. It wasn't necessarily from a source of truth. And so this has allowed us to have our bed meetings really be ran by source of truth, our OR schedules, what's currently requested in the doc line. In addition, leverage really those predictive analytics and the machine learning of Leantas that really has us being much more accurate. And then also those bed meetings now are for more value added things like, escalating a delay for a procedure. A patient's been NPO for 2 days and we need to escalate that to the right department. So now we actually have a bigger and broader bed meeting because we can include those ancillary departments for escalations where it used to be very nursing centric. And now we have this source of truth that we really leverage to do more value added work than just trying to get all of us at least on the same page.
Nice. Now we're going to transition into another part of the tool called the admissions queue. And again, these are certain parts of the tool. We're showing parts of the tool as is, and these are static versions, but the live version has other aspects that Jamie and I can highlight. This part of the tool really focuses on admissions flow, your incoming flow. And what is important to note here is we really wanted to hone in on where are your patients coming in from? Because that, of course, as you know, affects kind of the timing and the workflow that is involved if they're coming from a procedural area or from the ED, or are they a direct outlet or outside transfer? And this part of the tool also, as an audience, it really has been quite informative for our ER colleagues as the gatekeepers of the hospital, because not only do they get a quick glimpse of what the predictions are from these different sources of demand, they also can concurrently see, all right, what in the hospital on the inpatient side is going on from that predictive future piece and active real time that will affect my ED. And that's why we highlight the ICU space right up top here, because in this example, you're seeing the ICU is super backed up. That means something to the ED, right? Because that means all those critical care patients are going to have to sit in the ED till ICU and it has some more space. And that means critical care is going to going to be offered at a much bigger volume than it usually is, which has all kinds of implications on your nursing ratios and whatnot, et cetera. The second part of this tool focuses a bit more with the higher level kind of house supervisors or administrators, the folks who strategically help units manage their flow and also help to put out those fires when things happen, and also for patient placement. The group or bed placement, some people say, or the bed czars, the people who really do that connection of, I have a patient that needs to be admitted, I need to assign this empty bed to that said patient. Well, the reality is, although they will know exactly who needs to be assigned a bed, they have very little time and almost no data to understand how to do that in a smart way such that they are placing that patient in the best part of the hospital so that care is delivered in the way that it should be, and they're meeting all the different check boxes that they should to make sure that patient journey is going accordingly. Because as you all know, what often happens is when you are so full, you don't have time to think, patients that are that should be going to a said unit, for example, like an ortho patient should go to the ortho floor, sometimes that won't happen, or your medicine patient will end up on a completely different floor, or your geriatrics patient will not end up on the AC unit, and that has implications. So we've tried to build something that helps showcase that predictive piece of how patient placement should assign beds, and it also gives recommendations on how they should assign beds, because just giving the data isn't enough. They need to know what the next actionable step is. Jamie, can you speak to a little bit of what you have seen and heard with the admissions queue in Colorado?
You bet. You bet. So this isn't something we necessarily bring up at our bed meeting. To your point, it's something that my house supervisors will leverage to help them make decisions on getting our, high priority diagnoses to the right place. Okay. I would say the biggest usage of this has really been probably with our ED. And what they've been able to use it for is their internal flow when they're getting at higher volume within the ED. And it looks like they can tell by those red numbers that they're going to be holding for a while. Or very specifically, a stroke patient can only go to a neurosciences unit because of the NIH certification that those nurses need. They know that if neurosurgery or neurosciences is upside down, even if they aren't boarding, those patients are going to be in the ED for a while. And so what they will do then within the ED is actually so that they can keep their main area open for triage and, EMS and that sort of thing. They will actually move people that they anticipate being boarders for a while to our clinical decision unit, okay? Even if they aren't an OBS patient, but they will actually move them so that they can keep the ED functioning smoothly under those conditions.
And Jamie, one other question I had, I remember speaking with Dr. Michael, who oversees the ED at Colorado. Yeah. Mm-hmm. He was saying, kind of dating back to that slide that you were showing before, he would eagerly wait for those emails that would come out. So
all of us would kind of have this anticipatory anxiety throughout the day, where we were sitting at the intervals that the email was sent out by my team. So we would see, oh, have we made any progress? Are we still going to be boarding 30 by the morning? Oh, how were we in discharges? Ooh, have our discharge predictions dropped? Do we have orders? Well, now everyone can have access to this. I have this saved on my home screen as its own little icon, and I just click on that, and you can check at any point in time where we are going to sit as an organization going into the night, in the morning, where are we at right now? What's the ED volume? Do we have a ton of confirmed orders that we just need to get patients out? Are we waiting on orders? So it really does remove that anxiety, because at any point in time, you can very quickly see where we're at as an organization. So I keep speaking of chaos. That chaos day to day for both frontline executive clinical leaders, once they learn to utilize that tool, this tool really has decreased some of that chaos and help with their planning within their departments, even ED staffing. Dr. Michael's a provider, and he knows that he's going to have to run his ED a little bit different depending on what our predictive balance is compared to the volume, et cetera. But from a nursing perspective, if the ED needs to request staffing resources from our float pool because of, we're going to be boarding X amount by the morning versus, we're going to be okay, we don't need any staff. And so it really allows us to use our resources most efficiently and in the right places too.
Excellent. Let's see. So this is another part of our tool, and I will preface all of this with, this is not a full-on demo of the tool. We'll give information at the end of the session where we can really provide an in-depth demo of the tool. But this is a brief summary of something we call the transfer tool. Like I said, we were trying to find places in the inpatient clinical operation settings as to where does one have a little bit more control than one is used to, and where can we exercise that control and marry it with our predictive models to help manage capacity better. So one place that exists is when it comes to internal transfer activity, right? Now, as you all know, doing internal transfers, no matter where they're going, is a lot of work, right? And honestly, we usually prioritize, as we should, step ups, or anytime a patient needs ICU level of care, code blues happen, rapid responses happen, or admissions to ICU, anything on that end of the spectrum, we make that happen right away. We're great at that. What doesn't happen as quickly and as optimally as it should are the step downs or the transfers, because like I said, your geriatric patient is not sitting on the ACE unit floor. So moving them to the ACE floor becomes a second, third priority. And then, you know what, a couple of days go by and then you're already close to discharge, you don't get there. These lower acuity transfers is where we feel like there's actually an opportunity that exists. And so we've done a couple of things. One is we wanted to provide just a nice consolidated visibility around the different types of transfer requests one has, because as you can imagine, for the bed management folks, the bed placement folks, just knowing the overall summary of the different types and where they're sitting is very helpful to understand, okay, these are the kind of the pieces that we need to move. Now, the next piece that we're not showing here, but we speak to, which Jamie now has as part of her tool, is there is a recommendation engine that is going to pop up your top 3 or 4 transfers that is recommended based on our predictive models and which units need more space downstream. And so that helps to guide that next actionable step. These are recommendations, they are not force functions. So again, the human element is the most important. The clinician, the operational person needs to make that final decision. Does this make sense? But we now are giving them a set of options to even consider. Whereas before, they would have to unearth those options or be called out because, said unit nurse is actually great about calling them and saying, yes, push this transfer through, and it'll happen in that way. And in that sense, or in that setting, a lot of the transfer activity is really happening not necessarily based on what should happen, but who kind of has the loudest voice to make sure that their patient gets to where they need to outside of the critical transfers. Let me pause there. I want to give Jamie a moment to reflect a little bit about the transfer tool specifically.
Yes. So the patient placement folks who actually make the bed assignments here, and then my house supervisors, this has actually helped them piece out and prioritize what is most important. So our current bed management system does not necessarily alert or help people prioritize what to do. So on their board, when there's a bed request that comes up, whether it's a patient that they've intubated on the floor, that we've got to get to an ICU bed now, versus it'd be really nice to get this COPD patient on one of our hospitalist teams to the right unit that's another medicine unit. There's no way for them to piece that out. So this actually, with its colors and now with its recommendations that isn't reflected here on this screen, actually helps them make the best decisions. And so you can see the red. This gives my heart a few palpitations because those are actually there's a lot of step ups on this board right now. Meaning we have we have a lot of increases in level of care. And so those need to be prioritized now to get people to either step down or ICU from the floor. Some other things that this really allows us to do are our COVID units and our COVID beds. When we see those peaks in census that we're all learning how to navigate, this really helps us use our beds most efficiently. And so we can free up beds quickly to use for non-COVID if we're seeing that, for instance, that horizontal arrow indicates that patient now can go to a regular unit, they've been cleared. And so it really helps us use our beds most efficiently, depending on if we're in a peak in COVID or not. And so it decreases the banter that our teams have to navigate with our traditional bed management tool, and then helps them prioritize. So this is actually a really, they use this screen a lot to help them make decisions.
And Jamie, I think the other thing I know you and I have we've talked about this before, and we're looking to see how we can appropriately manage that workload for it, but how to get at those off-service patients, like you were saying.
Yeah.
Right.
So, we've traditionally, you kind of spoke to this. We know that lateral movement of patients between units is historically something our organization has said, you know what, it's not efficient. We are not going to move people around. We're so full. It's not a good use of our resources. And so what ends up happening is we have a high, what we call it, off-service percentage, which if you're a clinician, that means that you might have to round on 4, 5, 6 different units. And that's not efficient, and contributes to the chaos of our frontline teams. And what we're really doing is trying to shift that traditional, pretty black and white approach to lateral transfers, and using the prescriptive analytics with this tool that says, you know what, if we did these 2 transfers, we could really actually probably have 4 patients be admitted or transferred and be on service. And so if we can start, picking away a little bit strategically with that, to start to get our patients more geographically cohorted, that will ultimately really, really impact, the satisfaction of our clinical teams.
Thanks. Yep, that is a huge, also very difficult piece. It's funny, Jamie, we went live in February with you guys of 2020.
Mm-hmm.
So that was literally right when the pandemic was just hitting, and we did the entire thing virtually. I'll save that discussion. We'll talk a little bit more about that, kind of the implementation, how it went for you, because it was such an interesting time to go live also with all of this going on. We did want to just quickly review with you. Like I said, UC Health has been an extraordinary partner, especially Jamie, in that we are partnering to further develop and build out discharge-focused tools. So we have something called the Discharge Tracking tool specifically, that part of it functions as a real-time active progress report as to how all the units are doing throughout the day with regards to discharges. Now it pulls in particular estimated dates of discharge, which is EDD, something that UC Health uses and many systems use. Both nurses and I know clinicians can often provide that information. But as you all know, EDDs only can be accurate to a certain extent. There's a lot of variability in how those get put in. So in this part of the tool, we pull in our predictive models and marry that with the EDDs to show, all right, this is what we're actually predicting the number of discharges are going to happen. This is how the floor is doing. Which floors are on track, which are not, which are unexpected discharges, which folks already have DC orders and have fallen behind by greater than the 2-hour window, and we need to do something with DC barriers and discuss and et cetera. And it's geared towards capacity leadership, house supervisors, and even nursing unit leadership. So instead of them having to ask around, attend every huddle, wait for phone calls, they have an active board that they can keep track of and try to help mitigate and support each of these units as they either fall behind or are doing just fine. Jamie, I don't know if you had any other comments to add with the discharge tracking piece. Oh, looks like you're on mute. There you go.
I said I wasn't going to do that. I think the biggest thing with this is how easy it is to access the tool. So you spoke to, does that nurse manager or that nurse leader or house supervisor, they can't be at every MDR, every huddle, even signing into the medical record for people outside providers into the bed management piece, very clunky. You have to go through Citrix and all of that, where this is quite simply just a click on your home screen that you can very quickly see real-time data. And not only real-time, but predictive. And so this really does help leaders, help leaders to manage their time better, yet stay very engaged with what's going on in their units.
Awesome. And then the last piece of the discharge toolkit that we're putting in is called the Discharge Planning part of the page. And this focuses more, as the audience is going to be more your case managers and maybe your social workers and nursing and physician leadership. It not only congregates sort of, if you're unit-based or service-based when it comes to case management and disposition planning, how are the needs mapping up for that said unit or service? What are the top needs for that service? And what are the predictions as far as length of stay goes? Because that, obviously feeds into how you're going to do that discharge planning. Now, typically, as you all are familiar with, everyone is, having their version of MDR or multidisciplinary rounds where teams get a chance to weigh in on this is what's clinically happening, is the patient ready for discharge, et cetera. What unfortunately happens on the sidelines is case managers are met with this huge task of trying to prioritize how to really tackle their gazillion tasks that they have, whether it's to set up O2, whether it's to put in that referral for a SNF, whether it's to set up transportation, and the list goes on and on and on. And they try to grasp at the priority during MDR, but that is also variable, right? Because the quality of MDRs vary from system to system, varies from service to service. And also sometimes plans aren't put into place in the morning. People are busy rounding. Surgeons are in the ORs. And again, that whole arena can get quite complex. So what we wanted to do here was, using our predictive models and using current real-time data, pull in the needs and the priorities, and then actually give a prioritized list to our ancillary staff so they can really get at the lowest pieces of hanging fruit. And this automatically sends this automated email to case managers at the beginning of the day before they've hit MDR. And it gives them that prioritized list so they can start tackling their list even before they have to go to their MDR, and then they can adjust accordingly. Again, the focus of this is to improve the discharge delay rates, to improve that efficiency, and also really focusing on, if they're ready to be discharged, like, let's make this happen. So it's really getting at that particular piece. Jamie, I'll just maybe if there's any other comments you wanted to add to that particular.
I have a ton to add here. My care management colleagues work much more intimately with this tool than my house supervisors, but it's about when you put everything together and the synergy that these different tools with different departments create with patient flow.
Exactly. And so moving forward, we did want to give a moment to reflect on how the tool has performed at Colorado. since we've been there, like I said, since February of 2020, and I wanted to take a moment to give some room to what have been the metrics, what have been the results specifically at Colorado. Jamie, why don't you take us through some of these numbers, and then I'll reflect on the opportunity days and some of the other things.
Yeah, you bet. So that first one, that 37%, is a reflection in the time that we've decreased with our ICU transfers. So historically, in order to have a patient move through our ICU, our nursing colleagues would need to click that the patient was ready to move. And I have yet to see a bed management system that doesn't sort of leverage that workflow. That's an extra step for a clinician, okay? And then we're all human. The moment that you do transfer someone out, what does that mean? You're going to get an admission, right? So human nature, there's a little bit of that to play too. What this tool has allowed us to do is very quickly see where we have floor level of care patients in our ICU and start to assign those patients out to floors in order to keep ICU bed availability where we need to. So that has resulted in a 37% reduction in time that our patients move from the ICU to our wards once they're floor status. And that's freed up our ICU bed capabilities. It also allows us to not move into different access center delays and redirect protocols. And so that's been really instrumental here at our organization, is moving patients through our ICUs. We don't necessarily have an ICU capacity problem. We've traditionally had a flow problem, and we've really been able to address that with this tool.
Excellent. The other,
go ahead.
Sorry. The other comment I just wanted to make, Jamie, was we wanted to be very careful about what windows of time are we looking at to see if we've moved the mark on these metrics. Mm-hmm. So of course, in 2019, we were looking at towards the latter part of the year, using that as the baseline for you all. But we compared it to the same part of 2020 where it looks like, if anything, Jamie, actually your census actually went up further than your average even. So this is past that second wave and all that stuff with the pandemic.
Yeah. So this is all in the setting where our capacity and census, occupancy rate, whatever you want to call it, has actually grown too. So not only have we improved in these metrics, we've done it under those circumstances, while also managing COVID census operations in the pandemic. So pretty significant gains there in terms of patient flow.
It's been great because, and also, our tool is not operating in silo here. So that was the tech-based tool, I should say, that was providing support to you guys. Of course, as all great hospitals do, Jamie was also overseeing a couple of wonderful PI efforts, including their Project Flow, which makes use of the DC milestones and delays within Epic, and even their discharge lounge. So as usual, like any good system, there's also simultaneous quality improvement processes that were being put into play. But we are proud to say that we were the tech-based part of supporting all of that. So one thing I did want to highlight, so opportunity days at Colorado, specifically the way they look at it, which most systems actually look at it in the same way, is really looking at the length of stay of their actual patient population, in particular med-surg, and then taking the difference between that LOS compared to that of the CMS LOS for those same diagnoses. And then using that difference to define essentially what is called here opportunity days, but you can think of it also as kind of like an estimated excess bed night type of thing. And with all of these efforts in play and our tool going live at their system, they have been able to see a decrease, about 8% decrease, which is quite impressive. Like I said, even given that their census actually went up towards the end of the year in the opportunity days, which was a huge accomplishment for them. And it speaks to all the efforts that they put in. And then Jamie, I'm forgetting if you were able to reflect a little bit on kind of the decision making because of our predictive models and kind of your.
You bet. So we noted the 90% improved confidence in critical capacity decisions. So what we meant by that is making decisions on whether our access center will go on a delay or redirect protocol, decline protocol, or even when we talk about delaying procedures, et cetera, during the COVID pandemic. And what we've been able to do is that really using real-time data and predictive analytics that have proven to be phenomenally accurate so that we can make the best decisions. So historically, the decision that I might make as an AOC versus a decision that my colleague might make as an AOC that we make on a Monday versus a Friday. Now we use data and our predictive balance and bed balance to drive those decisions. So there's less gut and subjectivity and much more objectivity into how we're making decisions. So we've been able to do two things. One, stay off of delays and redirect protocols unnecessarily, but two, actually go on them earlier because we can see that we're going to be in trouble. So we've been able to sort of benefit on both ends of that spectrum because we're using that predicted balance to make decisions versus I'm not exactly sure where we're going to end up. Yeah.
Nice. I was just going to say, even when I was on our patient flow committee, I remember that feeling of like, oh God, we're getting busy. What should we do? We have like a gazillion extra additional meetings and we go on diversion. And then we're like, should we have gone on diversion? No, let's do, this constant back and forth. So
same thing here. So the amount of time and what we would do historically, we would go sort of stand up our command center, which was a little room with, director, VP level people to go make decisions, to escalate delays, to address barriers. And now that's just SOP. And we don't have to go all sit in a command center and cancel our meetings for the day. We really leverage this tool to guide how we make decisions.
So now we want to get into the Q&A, the remaining minutes that we have left. So please feel free to get in there and ask any questions. Let's see, we've got a few already. Are the predictive measures extendable in time to help with staffing decisions on the nursing level and the MD level? Jamie, I'll let you speak to that.
Yeah, so I can speak a little bit to that. We have given all of our medical directors access to Leantas. The emergency department uses this for their staffing, like I had indicated. If they need to request inpatient nurses because they're going to have X amount of boarders in the morning. Our senior director of our resource management center actually will use this because she can see across the entire system the utilization rate, how many ICU beds actually have floor patients, and to make decisions on maybe where some of those float pool resources are allocated. And in terms of extending it, the current tool, you can see the next shift, the next 2 12-hour increments. So like right now, I can see where we're going to be sitting at 1900 and then again at 0700. So that's how far we're able to plan at this point in time in terms of that staffing piece.
And I'll just add, I remember when I was speaking with your ED group, they've also modified their staffing, not only in the nursing level, but also sometimes on the provider level too, because they pull in additional people based on what they're expecting to see and et cetera, or, downsize depending. Jamie, one question that came in, I actually asked this a little earlier. Can you speak a little bit to how you manage the integration with the existing EMR. So you have Epic.
Yep.
And also, I will set the premise, like I said, this was right when the pandemic was just getting started and things like that. How was that for you? And how was the change management piece of that?
Really good question. So some key things for us, we really engaged our frontline leaders and some of our charge nurses, house supervisors in sort of building the tool and then creating that trust before we rolled it out. And so internally, we actually sort of tracked the predictive modeling and is it really, really accurate? And we did that just to prove a point with our frontline clinicians and leaders. We did that. And then we actually we gave everyone access. We gave very, very broad access. We weren't sure we were going to do that, but we ended up feeling that, the spirit of transparency was best. And when we did that, people just really got in and played and learned and learned to trust the tool. And so we really did ultimately rip the Band-Aid off. One day we said, this is how we're going to operate in terms of using the tool to drive our bed meetings. We did some preemptive, we offered education to our charge nurses, to our nurse managers. We went to our medical directors before we rolled things out. And then the other thing we did is this, a screenshot is sent out very broadly at our organization twice a day. And so it's truly the language we use to speak patient flow. And so it's really been integrated into everything we do and how we speak in order to get that buy-in. Leantas has been a great colleague and responsive whenever we've had a question, or, we'll have providers want to understand the analytics and the data behind things. And we've been able to do that. And so that has really sort of helped with that change management and buy-in piece.
The other thing, Jamie, so we didn't step foot on your campus since the pandemic. So we went live with this tool. I've actually never worked with you in person.
Yeah, we never met.
We never, physically met, but we do. That is the other thing, especially coming from kind of the physician angle, and also having gone through the go lives, when you transition to Epic or any other big tool, it requires a massive amount of time and effort from the frontliners, which can be quite frustrating. I was curious, what was the lift from your angle on your staff and disruption to workflow?
I got to tell you, we allowed our staff to get in there and play with it before we went live with bed meeting and saying, this is what we're going to be emailing out to our team. So we had a time period where they had access and could play with it before we went live. But the buy-in was not hard with my team at all, because the lift that they were doing at that point in time, everyone saw the burgundy and white spreadsheets that we sent out, was so burdensome in terms of the time that took each day for them to gather that data, fill it out, send it. Where now they have a link, they just keep this up on their computers. They do a snippet screenshot and they email it out. And they don't have to worry that the calculations are wrong or they copy and pasted wrong. It doesn't matter what time they send it out. If they are responding to a code or, a behavioral patient or a trauma, my team, and they're behind at sending that email out, it doesn't matter. Whereas our other process did matter, because the way that we had our homegrown formulas and analytics built into those Excel spreadsheets, that timing was supremely important, or it was all off, not an issue anymore. So the gain for my team did not take a ton of change management. I would say for our clinical leaders, nurse managers, providers, that just took more talking through so that they could build trust with the tool and understand what they were looking at.
Thanks, Jamie.
And
That's
how it
super
applied
helpful.
to them and their department. Yep.
That's super helpful. I guess we are at time. So with that, I will say there are many pieces of the tool that we do not review here, including the network visibility, the additional recommendations, and other aspects. If you would like to see a demo or have us just answer some questions, please just email nancy.s@leantas.com. Jamie's also, I know, Jamie, I'll just offer you up as a reference if people want to have some more conversations with you kind of from the nursing leadership angle as to how it went. And also you can contact me. It's paulav.s@leantas.com or my full name at ucsf.edu. But thank you all for joining today. We really enjoyed it. I wish we could have actually had an active discussion. We'll make sure we get to any additional questions that popped up that we didn't get answered to. Thank you again.